Hello friends, today we are going to deal about an important topic. The topic is algorithm to evaluate and treat RH incompatibility. Guys, this is a very important topic. We'll apply this algorithm directly without altering here and there. Will not alter here and there. It will directly apply this algorithm in our practicals, that is in our hospital. So we'll learn about this, and it is so common. We will see lot of cases in our hospitals. Okay, so let's directly learn about this algorithm. It's a very important algorithm, guys. Really very important. Any RH negative pregnant patient, if we see, we have to first just think about this algorithm. Okay, guys. So let's learn about the algorithm. So if there is an RH negative mother and it is her not her first pregnancy, if it is a second or third pregnancy, that is after her first pregnancy. So if there is a RH negative mother and RH negative partner, what we have to do? What is the first investigation that we have to do? The first investigation we have to carry out is an indirect Coombs test. It is indirect Coombs test. When we should perform this Coombs test, that is important. It is at 12 and 28 weeks. Okay. So first, if we find a RH negative mother and her partner is RH positive, it's RH positive, then what we have to first do is we have to do a ICT, indirect Coombs test, okay, at 12 and 28 weeks. Why this Coombs test is done? That we have to know. This Coombs test is done to detect anti-D antibodies. This Coombs test is done to detect anti-D antibodies. Okay. Let's not go into the detail of what is indirect Coombs test and direct Coombs test. First, let's see the formula, the protocol. Okay. So we do the indirect Coombs test at 12 and 28 weeks. What for this Coombs test is done? It is to detect anti-D antibodies. Okay. So if the ICT becomes positive or if the ICT becomes negative, what we should do? If the ICT becomes positive, I am writing it in a little hurry so that can complete it quickly. So my handwriting becomes a little bit bad at sometimes. So forgive me for that. Okay, guys. So coming back to the topic, indirect Coombs test at 12 and 28 weeks. It is done to detect anti-D antibodies, and if ICT is positive, what we should do, and ICT is negative, what we should do. What does it mean, ICT is positive? So ICT is positive means we can infer two things. What is the two things? What are the two things? Is either the patient is sensitized or immunized. Both of them are not synonyms. They have different meanings. Okay, let's see that. First, what does it mean? That means we have to first see the titer values to differentiate this. So what we have to see is ICT is positive, then we have to see the titer value. If the titer value is less than or equal to 1:4, it means it is it means that there is immunization which has taken place. Okay, immunization has taken place. But if the titer value is more than equal to 1.8, that is 1:8, it means that the patient is sensitized, and there is sensitization. Okay, there is sensitization. What does it mean? Okay, it means that if there is less than 1:4 titer value, that means that there is no extra antibodies which is coming to attack the fetal antigens, right? There is no extra antibodies which is coming to attack the fetal antigens. But if the titer value is more than equal to 1:8, it means there is some sensitization. There is sensitization of antibodies. There are some extra antibodies present in the blood. Okay, that's what it means. Okay, so this concept has to be understood very clearly. See, if there is more than equal, less than equal to 1:4, it means immunization has taken place. Okay, the antigen has been, overcome the antibodies. Okay, the antigen has overcome the antibodies. But if the titer value is more than equal to 1:8, it means antibodies are more than the antigen, and these antibodies are coming to attack the fetal antigens. Okay, now it is coming to attack the fetal antigens, right? Okay, it's clearly understood? Yes. So now let's see what it means that if ICT is negative. ICT is negative means it is unsensitized. ICT negative means it is unsensitized. What does this mean? This means that we cannot, we need not worry about this, because ICT is negative. So there are no antibodies. Okay, there is no anti-D antibodies coming to attack the fetus, right? Okay, so there is no antibodies which is coming to attack the fetus. That's what is this inference from this result. Okay, so ICT negative means there are no antibodies. What antibodies? Anti-D antibodies to attack the fetal antigens. Okay, guys. See, here also we said about antigens. No, yes, this antigens are more than antibodies. We said no. This antigen is a maternal antigen. The maternal antigen itself neutralizes. Maternal antigen neutralizes the anti-D antibodies. Okay, the anti-D antibodies. But here, the anti-D antibodies are produced in large number, where here in this sensitization, anti-D antibodies are produced in large numbers, so that the fetal antigens are neutralized and it's coming to attack fetal antigens. See, guys, clear? It should be understood very clearly. Here, anti-D antibodies are so extra, it is produced in excess amount that it neutralizes the maternal antigens and coming to attack the fetal antigens. Okay, it's coming to attack the fetal antigens. Maternal antigens are neutralized. See, maternal antigens are neutralized. It's neutralized. Okay, now it's coming to attack fetal antigens. This should be understood very clearly. Now, ICT negative means no need to worry. But what we have to do? Can we sit simply? No. We have to do something called as RAADP. That is routine antenatal anti-D prophylaxis. Okay, NDD prophylaxis. When we should give this? At 28 weeks. So we are checking at ICD at 12 and 28 weeks, right? So at 28 weeks you have to give this RAATP, that is antenatal anti-D prophylaxis, that is 300 microgram, which means 1500 international units. So 1 microgram is about 5 international units, right? So you have to give 300 microgram, right? Yes, guys. Now let's move to the next page. Now we are going to discuss in detail about the sensitization. Once the patient has been sensitized, there is more titer value. The titer value is more than 1:8, right? So what we have to do? So we are going to discuss in detail about that patient. So sensitized women, many sensitized women, okay. So the titer value for her or for them is more than equal to 1:8. So what we are going to do? What we should do? Let's check ICT. Check in the repeat the ICT titer 4 weekly. Okay, 4 weekly. That means monthly till 28 weeks. Okay, till 28 weeks. Then followed by 2 weekly thereafter. Right? Yes. Yes. So if the titer value is the same, or if it doesn't or does it increase that much, it's okay. But if it increases, what we should do? And what is the cutoff value? It is 1:16. Okay, titer value. See, initially it was 1:8. Now we are repeating the ICT titer value. So if it becomes equal to or more than 1:16, we have to do a new test. What is that? It is PSV of MCA Doppler. PSV of MCA Doppler. What is PSV? It is peak systolic velocity. What is MCA? It is middle cerebral artery. Okay, right? We have to do a MCA Doppler, that is peaks, to find the value of peak systolic velocity. If the MCA PSV, if it is more than 1.5 MOM, then we have to do a different intervention. Let's see what is that. But before that, what is MOM? It is multiples of meridian. It is multiples of meridian. Right. If this MCA PSV is more than 1.5 multiples of meridian, what you have to do? You have to directly go for chordosynthesis. In chordosynthesis, what we are going to see? We have to see two things. That is one thing. With different values means we have different interventions for that. If the hematocrit is less than 30%, there is a different intervention, and if it is more than equal to 30%, there is a different intervention. See, more than equal to comes at comes this side, right? Remember that, because many times what we'll do is we'll put less than equal to or more than equal to. When it comes to 30%, that is exactly, it comes to 30%, we do not know what to do, right? So just note this small things, it will be very useful. So if the hematocrit is less than 30%, what we should do? We have to see the gestational age. If it is less than 34 weeks, what we can do? We can do intrauterine transfusion. We can do intrauterine. I'll write it a little clearly. We have to do intrauterine transfusion. If it is more than 34 weeks, if it is more than equal to 34 weeks, what should we do? We have to deliver after steroids. And we can also do, what is that? What is this actually? IOL, induction of labor. Right? What should we do if it is more than equal to 30%? We have to continue pregnancy. Just a second. We have to continue pregnancy and repeat the chordosynthesis weekly. Repeat the chordosynthesis weekly. Okay guys, and do the induction of labor at 37 weeks. Do the induction of labor at 37 weeks. Okay guys, that's all. So for a sensitized patient, we are going to check the titer. If it is more than equal to 1.1:8, check the ICT repeatedly, that is monthly. 4 weekly means monthly till 28 weeks, and thereafter you have to check 2 weekly. Okay, if it is more than equal to 1:16, you have to do PSV, that is peak systolic velocity of MCA Doppler. If it is more than 1.5 multiples of meridian, you have to see chordosynthesis. And if the hematocrit is less than 30%, you have to see the GA. If it is less than 34 weeks, intrauterine transfusion, or more than equal to 34 weeks, it is delivered after steroids. That is nothing but induction of labor. Next, more than equal to 30%, if the hematocrit is more than equal to 30%, continue pregnancy, repeat chordosynthesis weekly, and IOL at 37 weeks. Before that, why we give steroids, guys? Why we give steroids? Why? What for? Steroids? Yes, it is for fetal lung maturity. Right? Yes, I think I said deliver after steroids, that is induction of labor. Actually, deliver after steroids, then you have to do induction of labor. Right? Okay. Now, what we have to do is, we have to see about the patients. Just a second. We have to see about the patients who are unsensitized. Okay, unsensitized. What we have to do? We saw here, right? Just a second. See here. Immunized patients, and here unsensitized patients. Okay, for them. And not only for them, after delivery, these patients can also be actually given this protocol. So what we have to do after delivery? See, after delivery, in particular for that unsensitized patients, okay, we have to do a direct Coombs test on, not the mother, on the baby. That's very important. If it's negative, we have to follow something, and if it is positive, we have to follow a different protocol. Let's see what we have to do if it is negative and what what we have to do if it is positive. If it is positive, that means the baby is sensitized. The baby is sensitized. So, giving anti-D would be of no use. Giving anti-D would be of no use for a sensitized baby. Right? Anti-D is of no use. But if it is negative, then it means the baby is unsensitized. What we have to do is give the 300 microgram. This is nothing but 1500 international units within 72 hours. You have to give it within 72 hours. Okay, guys? Yes. And there is a test called as KB test, Kleher-Betke test for all. Kleher-Betke test should be done for all. If you are interested in that, to know about this test, please refer textbooks. Okay, just or Google it also. You can see about this test. What is it? Okay, it's a laboratory test, right? So you can search and learn about it in details. But as of now, for this algorithm, knowing the name is enough, right? Next, anti-D can be given. Just a second. Anti-D can be. Anti-D can be given for up to 10 days. Okay, for up to 10 days, guys, after delivery. 10 days after right. So this is the protocol. So we're going to revise it. Just one revision, it will be enough. See, guys, what we dealt now is about the algorithm to evaluate and treat RH incompatibility, right? See, if you see a RH negative mother and it is not a first pregnancy, it is a second or third pregnancy, and the partner is a RH positive partner, what you should do? First, do a ICT, indirect Coombs test, at 12 and 28 weeks. What for this is done? To detect anti-D antibodies, right? To detect anti-D antibodies. What are these anti-D antibodies that we should know? See, a negative mother and a positive partner, positive father, then there will be an immunization reaction, right? There will be immunization reaction. There will be anti-D antibodies formed. Okay, so when this blood mixes, there will be anti-D antibodies. So if the child, the first child, for the first child, there is, just a second, for the first child there is no problem, there will be placental barriers. But for the second child onwards, from the second child onwards, the placental barrier would not be enough. So there will be mixing of blood, there will be many things happening. So we have to give anti-D prophylaxis. But before that, if there is any reaction, then we have to find it. So that's what for this algorithm is there. So this indirect Coombs test is done to detect any anti-D antibodies. Okay, if there is any anti-D antibodies. See, even if there is anti-D antibodies production, right, our own immune system, mother's own immune system has sufficient antigens to neutralize it, right? Maternal antigens are efficient to neutralize it. But if these antibodies are more, they are more in number, then what happens is this mother cannot neutralize it. Then comes the problem. Okay, so this is the concept. So indirect Coombs test is done at 12 and 28 weeks to detect anti-D antibodies. Now if the ICT is positive, we have to inference whether the patient is sensitized or immunized. We have to find that. Okay, only she is not unsensitized, so that we can infer. If ICT is negative means she is unsensitized. So if this ICT is positive, what we have to do? We have to look for the titer value. The titer value, if it is less than equal to 1:4, less than equal to 1:4, see that? It means she has been immunized. No problem. No problem. Right. But if it is more than 1:8, then there is some sensitization which has taken place. There is anti-D antibodies in her blood, right? That is which is able to attack the fetus. Okay, this is what we infer. But meanwhile, if there is ICT negative, then no need to worry. We can give the prophylaxis, right? Unsensitized. The patient is unsensitized. We can give RAADP, that is routine antenatal anti-D prophylaxis at 28 weeks. How much will you give? It's 300 microgram, which is nothing but 1500 international units. Next. Now, sensitized women. That means she has titer value of more than equal to 1:8 in her indirect Coombs test. So check the ICT titer 4 weekly. That is nothing but monthly till 28 weeks. After that, 2 weekly. Okay. Next. Or fortnightly, you can say it does. In that way also. If the titer is more than equal to 1:16, what you should do? Take a MCA Doppler. And what you are going to see in MCA Doppler, it's peak systolic velocity. Right. In this MCA Doppler, you are seeing the peak systolic velocity, and if it is more than 1.5 multiples of meridian, then we have to do something called as chordosynthesis. What you are going to see in chordosynthesis is the hematocrit value. If it is less than 30% or more than 30%. If less than 30%, you have to see the gestational age. If it is 34 weeks, you do an intrauterine transfusion. But if it is more than equal to 34 weeks, you have to deliver after giving steroids for fetal lung maturity, and then you have to do induction of labor. Okay, mechanical induction is there, right? The drug induction, that is chemical induction is there. You can do anything. Next, if the hematocrit is more than equal to 30%, continue the pregnancy, repeat the chordosynthesis weekly, and do the induction of labor at 37 weeks. Wait till 37 weeks and do the induction of labor. Right? Now, after delivery, do a DCT, direct Coombs test on the baby. If it is sensitized, then don't give anti-D, it is no use. But if it is unsensitized, give the anti-D prophylaxis, 1500 international units within 72 hours. And also, by the way, do Claire-Bidkey test for all. An anti-D can be given for up to 10 days after delivery. Can be given for up to 10 days after delivery. Right? Right. So, this is the protocol, guys. Revise this protocol. I believe it will be 100% useful to you. So, thank you guys and have a good day. Thank you. Meet you in next video. Thank you.